So welcome. Today in the studio, we have a very special guest, Professor Laurie Keefer, who is a psychogastroenterologist, an expert in the field, and a professor of gastroenterology and psychiatry at Mount Sinai School of Medicine in New York City. Welcome.
Thank you.
Professor is also the author of the psychogastroenterology textbook that we will be talking about later in this podcast. And we also have Professor Wojciech Marlicz, who is the professor of gastroenterology at the Pomeranian Medical University.
Yes, welcome. And thank you for invitation. And thank you, Laurie, for coming to Poland.
Oh, my pleasure.
We are in Poland now, in Warsaw.
Yes. And my name is Marii Marlicz. I am a doctor of medicine with some background in neuroscience, and I have the pleasure to lead this discussion today. So for starters, I think to introduce everyone to the topic, let's talk about what is psychogastroenterology.
Great question. It's a big word.
It's true.
So we really think of it as the application of psychological principles to gastrointestinal health. So we take a lot of lessons from experimental psychology, neuroscience, and clinical research and apply it specifically to digestive disorders.
Sounds wonderful. And so I have to ask a question, and it's probably to both of you at some extent. And it's probably a standard question, but I'm curious, how did you get to start your journey with the adventure with psychogastroenterology? Because you've been a leading expert for how long? It's been
over 20 years.
Yeah, 20 years.
Yeah.
So how did it start?
So it actually started when I was a doctoral student. I was introduced to irritable bowel syndrome at the time. My mentor, Ed Blanchard, asked me to conduct a study looking at meditation for irritable bowel syndrome. I remember at the time thinking, oh no, what is this thing? How am I going to tell my parents that I'm studying the bowels when I went to psychology school? But then I did the study, of course, and I fell in love with the brain-gut connection and how you could actually change what's going on physically by using concepts in your brain. And the rest was history from there. So I've been doing this 20 years now.
Yeah, and I think this is the times when the Rome Foundation was
Yes.
called. So maybe we can mention a bit what the Rome Foundation is, because we frequently talk about Rome criteria, Rome Foundation.
Yes.
But maybe we can explain briefly what the Rome Foundation is.
Sure. Right. So the Rome Foundation was really created with the idea of developing symptom-based criteria. Prior to this, patients were often told, we don't know what's wrong with you. We don't know why you have GI symptoms. And what the Rome Foundation really came in with was to sort of define and characterize these, what we call disorders of gut-brain interaction, in order to be able to study them, to come up with treatments for them, to be able to educate doctors, to teach patients about what they had, getting away from this idea of a wastebasket diagnosis towards more of a positive syndrome, symptom-based criteria. So that's really been the mission and vision of the Rome Foundation.
Yes, and the work of Rome Foundation has been incredibly helpful. But I didn't mention one thing, that Professor Laurie is now the CEO of the Rome Foundation.
Yes, I have.
It's a serious task, yes, to develop it further. I can remember when I was a medical student, because we were always told as a medical students, not about disorders of gut-brain interaction, but about functional disorders. Yes. So I think we had no idea, or we were suspicious what the cause might be, but we had no idea that there is a connection of gut-brain. We were suspecting this.
Right.
And of course, many doctors were using this in their practice. But at the same times, when I was a medical student in the 90s, we talked about functional disorders. And I think that was the time when the medicine was much pharmacy-driven. And the doctors were looking at disease like a one-pill solution.
Yes.
And it didn't work, yes? These disorders like irritable bowel syndrome, functional dyspepsia, which are disorders of gut-brain interaction, are so mind-connected that it's a not single pill solution. Yes?
No, exactly. And it really opened up I think the term disorders of gut-brain interaction has opened up communication so that doctors can explain to patients that we do know what's wrong with you, right? You have dysregulation of your gut-brain axis, and our treatments are going to target both the gut and the brain together. And I think that has really helped the field move forward.
So I also remember from my medical school, and I just graduated really, that we never really talked about the psychological aspect of many diseases, let alone specifically GI psychology. And then behind the scenes, we talked about how it's pretty common, right, for in the US and where you work to have gastro psychologists in the department to help. And I wonder what has been your experience with introducing that link, with connecting doctors with psychologists and kind of leading to that understanding of why it's important, because I can imagine there were some challenges along the way.
Yes. Yeah, it has been, I think initially most gastroenterologists, I think, who saw patients with disorders of gut-brain interaction knew that psychologists would be helpful. But trying to build it so that the psychologist is integrated into the care plan so that the patient doesn't feel like you've just sent them off to the shrink, right? That you're actually sending them to a member of the team has been the challenge. And, there's financial challenges of doing that. There's access challenges for doing that. And we've really had to kind of create almost a business model as well as a training model for gastroenterologists to be able to, and I'm sure you do this in your practice, to be able to explain why a psychologist is the right person to add to the team. And that has been really, a challenge and an opportunity.
Yes, I think we are observing this more and more, and I think the break point was when the dietitians were appearing in our field, because like 20 years ago there were no dietitians. Dietitians were undereducated, and it was really scary to send the patients and refer to dietitian. But now we have systematic education of dietitians in our universities. And now we can collaborate with dietitians. And we see a huge progress when the patient is going to dietitian and work through several weeks or months with dietitians. But I think it's not only about the diet that the patient is being educated, but it's just part of the psychological process that the patient gets the connection with other person who is not only seeing for 15 minutes in the office, but it's have a constant schedule of visits and so on and so on. But of course, dietitians are not trained enough to be psychologists.
Right.
So, and I think it's a high time to introduce also psychologists. Yeah. So we have like 3 pillars, like pharma-based and medical-based process. So the role of the doctor is to put the right diagnosis.
Yep.
Then to work with dietitians, and then to work with psychologists. And I think this has to work in a concert.
Yes, absolutely. And I think if you think of it as a preventative model too, because so much of the mental health issues and so much of the disordered eating that you see in these disorders is because we've intervened too late. Right? We've allowed them to just get worse and worse over time. And I think incorporating it much earlier on is really, going to improve the health system.
And I just recently saw that you managed to publish a very good paper in Lancet, Gastroenterology and Hepatology. And I think you're also covering the psychobiological model, which we can use to prevent this late outcomes appearing and use it in prophylaxis. Can you tell a little bit about this model?
Yeah, so in the psychobiological model, the focus is really that, symptoms arising from the gut or signals arising from the gut can be amplified at the level of the brain due to a variety of processes. And so if you think of this as symptom response, right? So we all have GI symptoms, but the brains of people who might be suffering from these disorders of gut-brain interaction are more sensitive to these signals. And that can be for a variety of reasons. It can be how they learned about health and illness as children. It can be because they've had a catastrophic experience. They've had to go to the bathroom somewhere unpleasant. They've had really bad pain. And so they've developed all of these responses around, fear, uncertainty. And those responses actually over time start to influence symptom perception. So it comes all the way back to the gut.
It becomes a vicious cycle.
It's a vicious
and then it fuels
cycle.
issues. Yeah.
Exactly. And so what we're trying to do in our brain gut behavior therapies is to break that cycle, right? And sort of teach new skills, because sometimes when you have these signals, the response is very appropriate, right? You have abdominal pain, you should probably stop what you're doing and think about it. But over time, those signals are no longer helpful, right? Those are misfirings. And that's where we're teaching people to be able to live with signals and not have that amplified
Can
response.
you talk a little bit more about those therapies and approaches and things you investigated
I would
relating
just
that?
intervene for a while, because I see from my practice that it's, for example, patient has a trivial viral or bacterial infection, and it triggers severe symptom, and then patients try to seek the medical help. But of course, because this infection is gone, the patient is being referred to many medical examinations like gastroenteroscopy, colonoscopy, CT scan, MRI, and nothing is there.
That probably adds to the stress as well, right?
And medical
just
doctor
amount
cannot
of procedures.
Address the question, saying, I don't know what's the reason, maybe this, but we can find it. So the patient is going from one doctor to another, and this amplifies this vicious cycle.
That's right. And, we talk a lot about that sort of giving that positive diagnosis up front, as opposed to running them through all these tests. Just delays treatment and also contributes to that, well, we don't know what you have, guess you'll just have to live with it, when really that's not the case, right?
I'll go back to the question about the therapies and the potential methods that you could apply, either as a psychologist or also a GI, a gastroenterologist, maybe as a first line of first aid in a way.
We know enough now about our brain gut behavior therapies that a variety of professionals, not just psychologists, can actually do a fair amount. So nurses, gastroenterologists, even dietitians. We kind of have, I'd say there's two major classes of brain gut behavior therapy. The first is probably the most popular, which is cognitive behavior therapy. And in that situation, we're really targeting the way that thoughts, feelings, and behaviors are connected in response to the GI symptoms. So you might see us encourage patients to try thinking differently about their symptoms, right? You might encourage them to behave differently. So for example, if you've been avoiding going out on dates with your, because you're afraid of having GI symptoms, we might actually push you to try a date, see what happens. What's the worst case scenario?
Exposure to certain.
Exactly. Exposure, trying to decrease avoidance that is, comes with these conditions. And then we may also help you manage the emotions of it, right? To feel less ashamed, to feel less stigmatized. And so CBT really kind of covers those aspects. The other class of brain gut behavior therapy is hypnosis.
Oh, that's interesting.
Which is very interesting too. And the idea behind that is that there are subconscious aspects of your brain that may be facilitating this brain gut communication. And if we can talk to you when you're in a more relaxed subconscious state, we might be able to break through some of those signals.
Could you explain that a little bit further? Because for me, it's a little bit of a mysterious term, hypnosis. No one really taught me about it in medical school, but it keeps popping up in different conversations about therapy.
Hypnosis is really, I think it's a great solution, and it can actually be delivered, in a variety of ways. It's a very accessible therapy in that sense. What we're doing is we're really kind of putting the patient into a relaxed state where they're more open-minded to suggestions. If I were just to say to you, hey, don't worry about your symptoms, they're no big deal, you'd be like, did she just listen to me for the last 30 minutes? But if I said that to you when you were in a hypnotic trance, in a relaxed state, in a heightened focus attention, you might be more accepting of that conversation. And so I'm using that sort of subconscious sort of experience. And this is how marketing works too, right? You're, did you, watch a commercial on TV and all of a sudden you're craving a Coca-Cola? We're doing the same thing, but we're very specific around what's going on in the gut. So for example, we might say, in situations where you might previously have felt really nauseous, now you feel pretty comfortable at this setting. And again, you'd say, if I said that to you now, you'd be like, what is she talking about? But when you're in the hypnotic trance, your brain can really hear that, and your gut can really be influenced by that symptom perception.
And of course, these are continuous sessions, yes? How many sessions, for example, you need to go with a patient? It's like a few sessions, or it's like constant relationship?
So that's a great question. Most of these brain gut behavior therapies are about 6 sessions. So they're short term, they're very skills based, and they're very targeted towards the GI symptom. Many times patients will continue to practice the skills after they're done with the therapy. And what we know from the data is that the outcomes sort of stay the same over time because they're really targeting those underlying issues. They're not just a pill, right? The problem of that, though, is patients do have to be able to dedicate time to the therapy. It doesn't work right away. You have to kind of be able to experiment with new behaviors, that type of thing.
So they also should be somehow convinced that it works.
Yes.
So it's probably not that easy to convince
and that's
the
another
patient.
Another question, because I wonder how are patients in the US, or specifically in the New York City population, because it all varies. But I know that, for example, I think in Poland, there's still a lot of stigma around going to psychotherapy or seeing a psychologist. And maybe you could talk more about how patients perceive it when they come with gastrointestinal issues, and whether it's somehow recommended to them or hinted at, or if they ask for it themselves.
The patients are not aware that the psychology therapy can help them. They probably look for solutions. They are more aware about the dietary choices, but the psychology treatment is still very unknown. So I think it's a role of physicians and maybe role of institutions or companies to educate people what the gut-brain connection is, how this influence one another, and what are the solutions.
And and I would say that we have data to show that the uptake of these therapies is really dependent on the physician's buy-in, right? If the doctor says you should go see the psychologist for this brain gut behavior therapy, the likelihood that the patient will and stick with it is much higher than if you were to just sort of do that.
So that's interesting.
The role of the physician can't be understated.
And how was it in your practice in US, when you can talk about maybe the efficiency of it, or how you manage to convince doctors, and if you can see results in efficiency, but maybe also economic perspective and general well-being of the patients, all those aspects.
So that's a great question. So we've really worked on being co-located, which I really do think is the important part. So when a patient comes to the GI doctor, they can also see the dietitian, they can also see the psychologist, right? And so the stigma drops significantly if you don't have to go to a psychiatrist's office to see, right? So by being there with the same professionals, the same front desk staff, they already are there to see their doctor, it really changes the dynamic. Number 2 is I embed when I start at a practice, I'm going into the office with the physician and
Mm-hmm.
I'm pointing out to the physician how I might be able to help.
Oh.
So instead of just, when I first started, we'd wait till the patient was crying or having a panic attack. And that wasn't really what my role was, right? And so being able to say, oh, wait a minute, I noticed that this patient was really complaining, had a lot of pain catastrophizing going on. The words they were telling the doctor were very amplified. They were very helpless. Here's where I could help you. And so as I trained all the doctors in my practice, they started to be able to pick up on that. And we created an order set so that the doctor can say now, refer to the psych team, because I noticed the following. I noticed catastrophizing. I noticed low resilience. I noticed avoidance behavior. I noticed quality of life impact. And then now that we've done this over and over again, it's become the culture and the practice.
Oh, that sounds amazing. Do you think in the Polish setting it could work out?
Yeah, I
Because
think it's very likely, and I think it's good to have a dedicated psychogastroenterologist and send the patient, convince the patient after education to go to see the psychogastroenterologist.
Yep.
And the psychogastroenterologist probably can evaluate the needs and in which area to work on with the patient.
Right. Yeah, exactly. And we also know that when you have that practice, a lot of times the psychogastroenterologist can offload the physician from the follow-up visits because a lot of what you're doing is reassuring.
This is what we are observing with dietitians. So if we have the psychologist, it can really offload the physician's work.
Right, which gets to the cost, of having that cost savings, because you can see more. I know you have wait lists, you can see more patients if we're
and the wait
managing
lists in Poland are really, really long, and for sure, many of them will benefit from psychological advice and therapy, and not need for waiting so long for a doctor. And I think if you wait 1 year for a medical visit, it really creates this vicious cycle. Yes, so the problems can be really, really deepened by this time.
Absolutely.
And do you think the psychiatrist, when the patient is looking for help for psychiatrists, because psychiatrists are also prescribing neuromodulators, which are working. Are they also aware as for psychogastroenterology and these connections, or not really?
Not as much. We've had, a lot of, we do have some psychiatrists in our, broader Rome gastropsych group. Many psychiatrists are not necessarily trained or engaged in the somatic side of
it's
medicine.
like a missing link, right?
It's the missing link
in the process.
Yeah. And so really, certainly the neuromodulators we know are very effective. A lot of times the gastroenterologists end up being the prescribers of those for the same reasons, the wait list, not finding a professional that understands that gut-brain interaction. So again, it takes a village to manage.
I think the reason also for not paying much attention to those patients by doctors is that these are not really serious disorders from their perspective. Yeah? Right. So this is not cancer, this is not hypertension, which can end up with stroke. This is just bloating, yes, or this is just some discomfort, which is not really life-threatening, and it's not behind the increased risk of serious disorders. But indeed, those patients have very low quality of life. And this can trigger lots of diseases, and I believe also the serious disorders like cancer and circulatory problems and so on. I think
health behaviors are affected, right? So if you think about somebody who's, even if they're struggling with something like bloating, they don't go to the gym anymore because they're bloated. They, maybe don't sleep as well at night because they're uncomfortable. So it turns into
they might avoid healthy food, which also
exactly.
So it's another part of this vicious cycle and worsening of health.
Yes, exactly.
Overall health.
And they probably then it adds up to shame, like developing shame, like feeling shameful, and then building stories around the problem and just getting stuck in those cycles all the time. And then I wonder if then listening to you, I'm wondering, because there is this question of whether an issue is more mind-based or more of a mind issue or more of a gut or body issue. And if it's even that important to know exactly? What would you say? Or because you represent a little bit different perspectives from the same, you could treat the same patient, but with slightly different perspectives.
Right.
What do you think?
So I think we can divide the roles. So collaboration is the key. So we collaborate with dietitians, psychologists, and also working as a medical doctors. And I think if we support the gut-brain axis from different sides, it's working. So for example, I can tell the diet, it's a powerful tool. And of course, this is the role of dietitians, but also we have probiotics or psychobiotics, which also can affect the gut microbiota, which can help to manage the symptoms. And I think not only gastrointestinal symptoms, but also mental symptoms. And we know that, of course, psychobiotics are probiotics, which are not as that potent as drugs. So you cannot expect the very robust effect in a moment. But if you think of adjuncts to the therapy or products which can support the remission of for example, depression, anxiety. So I think it's a nice add-on. So from the gut perspective, this is important. Maybe probiotics also prevent like infections when you travel, when you are stressed, when you have poor dietary factors. So the diminishing the risk of infection, which can also disrupt the gut-brain axis, is important. So I think the attention paid to the gut and to the mind, if they are combined, works the best.
Yes, absolutely. I totally agree, and I think that I always try to tell patients it's not important to distinguish, right? And we have to get your gut under control. We have to get your brain under control. They both have they're communicating through the vagus nerve. Stress is the universal, right? You can have physical stress. You can have a psychological stress. That's where the psychobiotics can be particularly helpful, as managing that brain gut.
Do you use them in US? How are they common?
They're increasing use in the United States, particularly when with respect to anxiety, right? And so I think for symptom-specific anxiety, which is one of our triggers for the psychobiological model, I think it can really help to just sort of allow people the space to sort of down-regulate pain and fear associated with symptoms. So again, not every person living with these conditions has an actual psychological disorder. And so I think this is where there is a lot of room to manage stress and symptom-specific anxiety without having to throw in the neuromodulator, without having to treat depression or anxiety in the traditional sense.
Yes, I agree. This is what I observed. Sometimes the symptoms will resolve quicker when you approach the gut, sometimes quicker when you approach the mind. So it's not always that we have to follow first the gut and then the mind. It varies, I think.
Yeah. And anything somebody can do for themselves, I think, is also putting the power back to the patient. I can take this, I can eat this, I can exercise around this. I think automatically improves that overall brain-gut communication, right?
Yeah, and it's also about developing, I like the part about giving power back to the patient, for the patient to understand that they are also responsible for their well-being in some ways. There are things they can do for themselves and like build resilience. I'm thinking about that too. If you could talk about that a little bit more, because I think it's a powerful tool that can be developed.
Yeah, and I actually have switched, in the last 10 years or so, away from some of the pathology, the psychopathology associated with these disorders, more towards a resilience-based framework, because I think resilience fits really well with the autonomic nervous system, the body's ability to adapt to change. And so much of what our brain-gut behavior therapies do is teach people to be able to adjust to their environment. So how do you regulate uncomfortable sensations? How do you regulate your food intake? How do you adapt to the fact that maybe you have a sensitive stomach? The more we can use the positive psychology traits, the humans are naturally resilient. Sometimes we forget that, but we can adjust. I think the better people do. And the gut is also resilient, right? The gut has neuroplasticity. You can alter the microbiome. You can alter the neurochemicals and the hormones. There's a lot of room to play with.
And it constantly interacts with the environment, right?
Exactly.
Yes.
Yeah, and I think this also regulates microbiome. You don't need to take maybe special measures to the gut, but also improvement of mental health is directly influencing the gut, and vice versa.
That's right, exactly.
So then when we can maybe talk for a brief moment about another paper that you published. We talked about it behind the scenes a little, about the social determinants of what impacts our bodies. If you could talk about it a little bit more.
Yeah, so we had a paper that came out just this week.
So it's very fresh.
Really kind of looking at the brain-gut microbiome axis. It was a review paper published in Clinical Gastroenterology. And it really kind of looked at, obviously at the individual level, there's a lot of things people can do to support their brain-gut microbiome axis. This paper was particularly focused around eating behavior and obesity. But one of the highlights of the review was that even when you're doing all these individual things, we can't separate out the context in which people are living. And we know that experiences of food insecurity, poverty, racial and ethnic discrimination, all of those things early on in life set the microbiome up, they set the brain-gut axis up, and they can even influence what foods we crave, how much we eat, our ability to sort of control hunger and cravings. And I think that's really important because it's, we can teach people skills later on, but there's a setup that happens that's very environmental. And we need to be thinking about that for patients as well.
I feel like it opens a new perspective, like a new window in medicine in general, to take these into consideration. I wonder how it plays out in, for example, different cultural settings. For example, in Poland, with the history that we have, let's say, or the environment the climate even that we live in, and how it all plays out. I think it would be
absolutely
really interesting
in
too.
Poland, I did some nice walking tours yesterday, and I was really struck by, the impact of, the intergenerational trauma that
for sure
has,
that's probably very prevalent.
But then also the intergenerational resilience, the Warsaw Uprising, and all of that, and it kind of made me think about just sort of again, how do you leverage that conflict between trauma and stress and context with sort of resilience and the mindset of we can prevail, we are in solidarity. So I thought that was very cool and very relevant to the brain gut.
So I think it's also it's a proof that probably if you think about studies and research, they should be placed in this special geographical location. So it's probably not always easy to extrapolate the studies like from US to Europe and vice versa.
That's right. And I think this is why training, gastropsychologists in Poland is so important, because there's a context that we deliver our brain gut behavior therapies in that really doesn't, there's similar themes, but I think being so much of what we do is personalized to the patient's specific situation, and you really do have to understand the culture. In New York City, we have a variety of culture, and one of the things I love about it is being able to really dig deep into how do people's beliefs about their health really translate based on their life experiences, and it's definitely
it's incredible. I find it incredibly fascinating. Should we talk maybe a little bit more about the psychogastroenterology section in Poland then? Speaking about
this is actually, I think we follow Professor Laurie initiative, because
absolutely.
I think the US section at the Rome Foundation was set up in 2017.
Yes,
2017.
Exactly.
And I found out about the section when I became a fellow of American College of Gastroenterology and attending KCG meetings. Since that time, I followed the Rome Foundation initiatives and Laurie's papers. And then we thought, well, as a medical doctors in Poland, we were always aware that stress is important and stress sets on, but okay, it's not enough to know that the stress is important. We have to do something about it. And we thought maybe more structural way to develop this field. So we set up the section of psychogastroenterology section within the Polish Society of Gastroenterology, and with an aim to act very wide, to create courses for psychology, psychotherapists, maybe nurses, so medical health professionals who can use these skills, psychogastroenterology skills, to help doctors and to manage our patients with disorders of gut-brain interaction. But we also wanted to involve the patient societies. For example, there is a society of people with celiac disease and on gluten-free diet. This is very, very active society. They're so the IBD societies of patients. Yeah. So I think we want to get feedback from them. So not only act as ourselves and be blind for patients, but we want to have feedback how they perceive it. And we also like to run longer and shorter courses, but also to involve maybe cultural institutions like museums, like any musical institutions, to maybe create environments, friendly environment when the people can build this resilience and can become more confident and relaxed. So this is a wide initiative. And this psychogastroenterology section was set up last year, and tomorrow there is a Polish Congress of Gastroenterology. Laurie is a special guest to this congress, and we will have a psychogastroenterology section with 4 lectures, and this section is under the auspice of From Foundation. So we're looking very, very, very much to it, and I think we will develop this field for the future. And one of the key elements we will be using in our education is a book, and this book is Psychogastroenterology for Adults. This is a book where Laurie Keefer is one of the authors. So it's a great book. And Laurie, maybe you can just talk briefly about this book itself. What this book is about.
So I'm really proud of this book. It was it's a compilation of chapters on the different aspects of psychogastroenterology. So we start out really talking about the pathophysiology, the psychobiological model. How do you assess patients for these kinds of conditions? And then we move into sort of the unique psychosocial aspects of different conditions. And as you mentioned, this is not just about disorders of gut-brain interaction. This can be, we have chapters in here about cancer, gastrointestinal cancers, obesity, inflammatory bowel disease, celiacs, and food intolerances. So what are the unique quality of life impacts of that? And then finally, we move into the treatments, right? The modalities. So how do you deliver as a psychologist cognitive behavior therapy? What about gut-directed hypnotherapy? What about self-management training? And really kind of go through there. So I see it as like a textbook that I think can be really helpful. I know in the US, this book is often assigned in health psychology classes to sort of begin to introduce it. I would love to see it in the medical school training as well, because I do think it kind of gives you a good sense of the why.
Absolutely. It's being translated now, right?
Yes, actually, we managed to get rights for publishing rights, and we are this book is under translation. So I think this book will take us next several months to have it fully translated, which will be also translated by key Polish psychologists, psychogastroenterologists, psychiatrists, and gastroenterologists. And I think we'll be able to use it in the Polish version and use it in our education.
And already people in that, because I joined the course of the psychogastroenterology.
Yeah, this is the course which is organized by Center for Behavioral Therapies in Warsaw in collaboration with company SANRPOBI, which is also a great supporter of gut-brain axis. And Maria, it's a participant. Yes, you
I am a participant.
Almost about to finish the course. Yes,
and we've been already using that textbook. Some people brought it and shared it with others, and so I would be really optimistic here because there are wonderful people who joined the course, and a wide variety of professions. So from doctors to psychologists and dietitians and psychotherapists too. And I can just tell that a lot of those professionals are already working with psychogastroenterology on their own even, and they just needed a place where they could learn more about it and connect with other professionals to fill the gaps in the understanding. But I can tell that they already know a lot about it, and there are also a lot of patients, maybe some of them are watching us, and also we also could be the patients, right? That need the help. They already are getting help in some places, but I would be really optimistic about just putting it all together.
One of the aims is to create the referral list and the map of the centers where the doctors can refer the patients, but also where the psychologists or psychogastroenterologists can get a feedback from doctors. So I think this is very important. Does it work in US?
That's exactly right. I mean, we've really tried to create a directory, because one of the complaints that I hear from gastroenterologists is that they'll send the patient to a psychologist in the community and they'll never hear back. So they don't know what happened to the patient. They don't know if the patient actually started to work on their GI issue, or they're just there to talk about, their mother. Having that connection of expectations so that there's a shared, experience, I think is really helpful. It's more satisfying for the psychologist. It's more satisfying for the gastroenterologist. You feel like you're
for the
really,
patient.
and for the patient, of course.
Exactly.
To have that, patients really appreciate when the psychologist calls up the gastro, or the gastro calls the psychologist and says, "Hey, I'm sending this person over here because they're struggling with, fullness after eating or something." Yeah.
Should we ask for the autograph? I'm wondering in the
book.
Right.
But do we have a pen?
Do we have a pen?
We just need a pen, which is missing on the table, but we'll ask Laurie for an autograph.
Oh, wow.
It will be great. So it will be an author book. We'll keep it for our...
and I'm really excited about this because I think, being able, what you've done here in Poland and the way you've engaged, I think is applicable to other countries that maybe are thinking about doing this. And,
I think there is we already talked, maybe it's also good to involve World Gastroenterology Organization, because WGO is a member society for 100 societies all over the world.
Right.
And we have different courses like Train the Trainer course. And I think to go global and try to develop this idea and have some kind of a supervision, or maybe not supervision, but advice to these societies will help to develop this field globally.
Yeah.
So
exactly, and like you said, each country has its own context,
so this is very important. So we're looking really forward maybe for this global collaboration with the Rome Foundation, WGO, and
it's amazing.
And we are trying to to test it on the Polish ground. So
yes, it's a pioneer.
So thank you very much. This is a pen, so we will be really delighted to have your signature in the book.
I'll put it maybe I'll put it right here. Okay.
Great, thank you. It's a great honor to have this autograph. So we are now fully competent to translate this book and use it.
Exactly. Yes. You heard it here first.
Okay. Thank you very much.
Thank you so much for
coming a long
coming
way and spending time with us, and for great advices.
And we're looking forward to see what happens next. So thank you for this wonderful conversation. Thank you, Professor Laurie Keefer and Professor Wojciech Marlicz. We were talking about psychogastroenterology, and I hope that you found it interesting, and I definitely feel inspired for the future. Thank you so much.